let me just give a little introduction. Shireen, along with Mary, are our postdoc fellows in global mental health implementation science. This is mainly to introduce them to some of our the new members of our meeting today. Both of them were selected through a very competitive selection process, and Shireen is based at the Aga Khan University in Pakistan, and Mary is based, she spoke at the last lab meeting at the Aga Khan University in Nairobi. So Shireen is going to present to us her doctoral work,
yes,
but importantly also talk a little bit about her plans for her research as part of the postdoc.
Okay, so before I move into the presentation, let me ask a few questions from you. And it's up to you. You can respond by raising your hand. You can just nod your head, and you can even reflect silently. Okay, so my first question to you is, do you have ATM?
ATM.
Can you use your own money without asking anyone else's permission? Can you decide what you would be eating at dinner tonight? Yes. Can you make a decision to use any healthcare system without any interference, without any discussion? No. Okay. Can you decide your life partner without any pressures from society or family? No. Yes. Can you decide how many children you can have and when you want to have? So I can see the answers by when you raise your hand or when you nod your head. But just think about millions of women in Pakistan whose choices are restricted and influenced or controlled by either their family or societal pressures or cultural expectations. So now let's go and start the presentation. Okay, so this would be the roadmap. I'll take you to the Pakistani context first, and then perinatal mental health. I'll quickly define what is resilience, and then we'll move to the PhD research. And then I'll be discussing about my postdoctoral fellowship research plan. Everyone is ready? Yes. Okay. So let's hear the story of Amina. Amina, a young girl, was born in a small village in Pakistan. She had big dreams. She wanted to study. She wanted to become a teacher. But her family was suffering from poverty, and they could not afford her education more than 5th grade. They prefer to get her brother educated because they think that this is more important for a son. But so she just had her education up till 5th grade. When she was teenager, she has been asked to marry a very much old man, and she has not been asked for the consent. At her early 20s, she has several children, and all without her consent. And also her husband was unfaithful, did abuse to her, and on top of it, her in-laws, who actually bombarded her with lots of household chores, unended chores, and she got tired. She ended up having the frustration, and also these all struggles lead her to the mental health issues. And this is not the only story of Amina only. This is the story of millions of Pakistani women, because this uneducation, lack of education, unemployment, domestic violence, preference among boys over girls, this is very common in Pakistan. So with this, I'll start the Pakistani context. So Pakistan is a land of diverse cultural and socio-economic group. So Pakistan is at the south part of the world, and our neighboring countries are Afghanistan, India, China, and Iran. And this is where I belong to, Karachi, the southern part of Pakistan. Okay, so those who are interested to know the historical side of Pakistan, so Pakistan is a rich in historical places. We have the ancient Mohenjo-daro, we have Lahore Fort, so which actually portrays the history, archaeology, architecture of Pakistan. So those of who likes natural places, so here is Pakistan. So you can see big mountains, green valleys, big seas, and trust me, I have not been paid by any official travel country. It's just my love for my country. Okay, now let's see the division of Pakistan. So 30% of Pakistan is based on this urban part. Then it comes to the semi-urban side. And then rural side of Pakistan, where the 65% people live in the rural part of Pakistan. So now this division connects us with the challenges. So as Diana has already mentioned about Maslow's hierarchy, so we are still facing the bottom part. We are still suffering from the fulfilling the physiological need and this COVID, economical instability, political uncertainty, this has further pushed us towards the below poverty line. Illiteracy, gender inequality, we are still facing this gender discrimination. Females are not allowed to go alone for any healthcare services until unless they will have a male family member. Stigma is still very common. Most of our Pakistani population still believes in traditional healthcare system. They still go to the Hakim or the religious believers. Okay, so let's see the Pakistan demographic data. So the total population is nearly around 253 million. And you can see the population pyramid. You have a broader base. It means more youth, more young people. The maternal mortality rate is 183 per 100 live births, which is very highest among the South Asian one. And you can see the literacy rate. And females is just 46%. If I talk about the healthcare system in Pakistan, so though we have a public sector which is run by the federal and provincial governing body, but 70% of our population are taken care by private sectors. And also 78% of our population use their out of pocket money for using the healthcare services. Okay, so if we talk about the quality and accessibility, so we come up at the 154 rank out of 195 countries. We are far behind India, Sri Lanka, and China. We have inadequate health services, infrastructure, and shortage of experts. If I talk about the psychiatrists, only 50,000 psychiatrists have been registered up till now, which means one psychiatrist per 450,000 population, which is very less. And we have one bed per 1,584 people, and for psychiatric hospitalization is one bed per 50,000 people. You can imagine 90% of our population who have been gone through the mental health issues are often untreated. Okay, now let's move to the another segment of perinatal mental health. So what is perinatal mental health? It refers to the women's mental health from the conception of child to the first year after giving birth. Most common symptoms that occur during this perinatal time is anxiety and depression. Now, how common it is? So globally, 1 in 5 women experience mental health issues. In low and middle income countries, it is in 1 in 4. And if I talk about Pakistan, it goes up to 60%. 3 in 5 women experience mental illness. Now, what are the causes? So I use ecological model to explain this. If I talk about individual, so the demographic factors, the younger they are, and younger, if they are younger and have a pregnancy, so it means teen pregnancy, they are more prone to have mental health issues. Likewise, if they have previous mental health issues, any other comorbidity, they are more prone to have mental illnesses. Also, lack of knowledge, lack of autonomy, this brings them towards more prone to the mental illnesses. Also, if they have a bad relationship with the partner, also if they are going through the domestic violence or intimate partner violence, they have witnessed their parents being violent with each other. They have witnessed any during the childhood, if they have witnessed any childhood adversity. So there's all impact in individual mental health. Also, some communal level issues, like if they don't have a social support, if this is they are going through towards the they are from the poverty group, or also they are from mainly they are facing the gender discrimination at the societal level. They are not aware about their own rights. These are all the factors that impact and then that lead to the mental health issues during their pregnancy phase. And what are the impacts? So if mental illness in pregnant women is unrecognized, undiagnosed, untreated, it can lead to the devastating impact of women. That includes preeclampsia, severe depression, complicated and preterm birth, complicated pregnancy, stillbirth, abortion, violence, conflict, loss of productivity, economical loss. These are the impact that occurs on women. But it also impacted on children and infants. They can have cognitive and behavioral issues, developmental issues, motor delays, physical issues, low birth weight, stunning, malnutrition, incomplete vaccination, and delay in creating that bond between the parent and child. Now I'll talk about my personal journey. Being a mental health nurse, working in a community for 15 plus years, I have worked with the community, women for them, and I have witnessed them suffering through several issues. Like you name it and they'll have it. Be it domestic violence, be it literacy issues, be it husband's infidelity, right, gender discrimination, and they were facing all those issues. And I have seen them suffering. I have seen them. There were cases which were severely depressed, severely anxious. There were some who were going through the suicidal thoughts. Some also attempted the suicide and failed for the suicidal attempts. But in the same group, I have noticed that there were some women who were belonging to the same community, living in the same context, going through the same situations, but they were managing well. They were coping well. They were striving. They were like smiling. They were happy. So this connects me with the concept of resilience. So now I'll discuss about what is resilience. Anyone can try. What is resilience? Okay. Okay, so resilience is a concept of positive psychology, and it explains the inner strength, coping, inner power, and if a person is resilient, it means he has a capability to cope with adversity with a positive approach, with a positive attitude. Like if we can consider example of tree who has just grown again with it after a destruction. This actually help us to learn that life will go on, but we always should have a hope, and we can always grow again. Okay. So through my research experience, when I was working in a community, though we realized that this is resilience, which is helping those women to survive and to cope well. And we wanted to assess that construct in the community, but there was no tool available at that time. So as part of my master thesis, I validated a resilience building scale for Pakistani population, for Pakistani women. And then we used that scale in different population within Pakistan, in different cities of Pakistan even, and in diverse population that includes married women, married couples, infertile couples, teenagers, older adults, patients with like palliative issues, oncology issues, and their caregivers as well. Also teachers, healthcare workers. And then based on this assessment, we identified that if a statement in a resilience scale can bring smile on their face, how different we can bring if we'll have something related to like promoting resilience. So we should come up with a resilience building intervention. And this connects me with my PhD study, where my goal was to explore resilience and their core characteristics. We wanted to develop, validate a resilience building intervention, or also to evaluate an intervention into a pregnant woman, and wanted to see the pregnant women's resilience, depression, marital adjustment, and anxiety. So my PhD research study was based on two-phase trial. First formative phase objective was to develop and validate SMART module. That is, and we named them SMART because we wanted to have resilience training for safe motherhood for pregnant women. And the second phase was to evaluate the effectiveness of SMART intervention among pregnant women. So this is the summary of phase one, though I'll be explaining in detail. But we started to take the insight from pregnant women and from mental health experts, and which help us to develop resilience building intervention content. And then we developed our intervention. And once we have developed our intervention, we again take the validation from the experts. That includes mental health experts, which includes psychiatrists, psychologists, mental health nurses, and also the maternal health experts. So how we have started? We started taking the interviews from the pregnant mothers. And as we know that we really wanted to know what are the core characteristics of resilience. And we know that at one point in time, they may not be that much vocal. They may not come up with the actual data. So we utilize different strategies during our in-depth interviews. So our in-depth interviews were not traditional one. We use vignettes, we use like ecological modeling, we use the subjective modeling, we use photo elicitation during this in-depth interview. So interview were done with the mental health experts too. And these experts were were altogether 8 for each group. There were psychologists, psychiatrists, and nurses, and all from both the side, from public health system and from the private health care system. So this is what we have identified. One of the major core characteristics of one's resilience is finding the purpose of life. So we identified in our data that the women, they don't have their own personal goals. Their all goals were related to either child or either a husband, or related to the family, but they don't have the, oh, sorry, what happened? So they didn't have anything related to themselves. The second thing that we have identified, that they really wanted to learn how to deal with different emotions. That includes the angry emotions, sad, upset. So they wanted to learn the names of emotions. They wanted to learn how to manage those emotions, because they have experience either through the relatives or they feel themselves. So this was the second characteristic as identified as a resilient for resilience. Third was believing in yourself. So decision-making power, self-confidence, self-believing, not giving credit to self. So these are, if these terms are positive, so we found that they wanted to learn those skills to build their resilience, and those terms which are negative here, they wanted to give away those practices. Adapting optimistic approach. So they want, like during the qualitative interview, identified that these are the themes: life goes on, happy and contented, being hopeful, being positive, being courageous. The fifth point was strengthening support system and relationship. So unrealistic expectations, balancing relationship, family role in maintaining relationship, internalizing spirituality and humanity, faith, trust, gratitude, and humanity. So this was the outcome of our first phase. And based on this, we considered the pathway towards resiliency is finding the purpose of one's life, they should know how to deal with emotions, believing in themselves, developing optimistic approach, strengthening support system, and internalizing spirituality and humanity. So this paper has all the data related to the first phase of formative, where we included the participants, the pregnant women, and the experts. Then the phase comes where we actually started developing the intervention. So this was the SMART booklet, which is based on like 250 or 280 pages. And we considered each theme as a module or as a concept to be taught in a session of, and that I'll talk about the session, how long the session was. But we, during the development, we utilize different teaching strategies, considering that we are dealing with adults. Even I myself, I have attended 2 weeks training to learn teaching and learning strategies for teaching adults. So I each module was based on different innovative strategies, and these were based on contextual understanding. Like one of the example I can give for this particular, we used an activity and we named them the recipe of biryani. Biryani is a dish which is very common for Pakistani population. So everybody has different taste, everybody use different recipe for their own self. So through these activities, we teach them how to come up with your own purpose of life. So this was our first module. Second was dealing with different emotions, believing in themselves, yourself, optimistic approach, strengthening support system and relationship, and internalizing spirituality and humanity. So once we have this, we developed this intervention. We did the Gunning Folk Index, and we because the intervention was developed first in English. So we did this index, which helped us to make it more easy to understand, more comprehensible language. And once we have this up to the grade of 7 to 9 grade, then we translated into Urdu, and we made sure like we have asked the lay community people to read it and help us to make it more easy. And again, we went to those experts again, and we asked them to do the to read and to go through the each module and then grade them. And we calculated the content validity index, and it came as a strong to perfect. We also asked the experts to give us some qualitative comments, and they gave us that it is still contextually and culturally relevant. You have included innovative and engaging activities. They appreciated the consideration of different learning styles, and also every activity we have the facilitator guide as well. So they appreciated that. They gave some feedback on formatting and language, and so we did make amendment accordingly based on the feedback. They also suggested to have, like if you're sharing stories, so have those stories with, and have the flipped charts with those stories. So those who are a visual learner, they can hear it and can see the through pictures as well. So we amend our module based on their feedback. So all the process has been published in this paper. Now let's move to the next part of the intervention phase. Next part, that's where we did the block randomization trial. We started with the pre-intervention, and then we assigned the allocation to the intervention and control group with the block randomization. So 100 was in group control group and 100 were in intervention group. So control group received the flyer, which was their usual practice. So there was no psychological support group available, support system available, psychological counseling available at the centers, at the antenatal centers. They were just giving the flyers related to the family planning or related matters. So we follow the same thing. We made a flyer, a brochure based on the resilience building tips and coping tips. So we gave them to the control group and to the intervention group. And the intervention group also received the SMART intervention that lasts for 6 weeks, 1 session per week, and that was between 60 to 90 minutes. And then, so each session was 1 in 1 week. And then after 6 weeks, within the 15 days time, we had their post-assessment. Okay, so I did as I developed the module, I was part of the training. I did the interviews, I did the assessment by myself, but I wasn't part of the intervention. So I was blinded with intervention, but I trained all the facilitators, the midwives by myself, and the training was like 2 weeks long. So after this training, we had an evaluation for the midwives too. So we evaluated how they performed. We actually made the same group session format. We were in a group and we were acting like the same participants. So we were testing them, how they are actually going to transfer this intervention. Then we, our sample size was 200. We did permuted block randomization. Block size were 4. And ratio was 1:1, just to have this idea that we should have equal group, equal representation in a group. So after 5 blocks, when we have 20 participants, we made a group of 10 individual, and we started a session. One cohort was started with the intervention session. So 10 people in one group for one session. And these were our outcomes and our measures that we used. The study was done during the COVID time. Let me share this here. Though we discussed several times within our team that whether we should, because everything was stopped, whether we should continue this research or we should also take a break. After several discussions within our team of supervisory team and within the local community people, we decided we should go ahead and continue with the intervention, because this is the time where we actually test the resilience. And as part of service, we should also continue, because we don't know whether the result would be positive or not, but at least we should continue. Okay, so intervention session were done at the Kohikote. Kohikote is a setting where it is the only setting, government-based setting, which is run by the midwives. So you can see during COVID time, we make sure we have a proper distancing. So some sessions were indoor, some sessions were outdoor. Okay, so we started with 100. Coincidentally, we have exact number of protocol. So 23 in each. So this is absolutely coincidentally, but there were some reasons different between both the groups. But at the time of analysis, we did intention to treat analysis. We input the data based on last observation carry forward method. And our results we found significant difference in resilience score between intervention and control group. We found significant difference in depression scores between intervention to control group. However, there was no difference in the marital adjustment score. There was no difference in the anxiety score between the groups. Though there was a significant difference within the group, but there was no difference between the groups. So we also did several sensitivity analysis, like we did the difference in difference analysis. We did, including the dropouts, we did analysis excluding the dropouts, just to see how our data performs. Okay, once we are done with the randomization trial, we asked all those participants who attended all 6 sessions. So who were with us for all 6 weeks. We invited them, we asked them about the intervention. And there was some data, and it was 4 focus group and 6 in-depth interviews. So there was some feedback from the participants, like the story of Muniba Mazari has taught me courage, patience, and made me grateful for everything. One of the participants said, the classes were refreshing for us. We forgot all our worries. I felt so good. One of the participants said, no matter how hard the life is, but we need to be hopeful and move forward with positivity. Not only this, we also invited all the community midwives who were our trainer. We did their debriefing sessions as well. And we found, and this was the first time they've been asked, they came out from, because they were from the same area. And we invited them to the Aga Khan University. So, and we had their debriefing session over there. So you can see they were happy came there. So they said a special bond was formed with participants, and that attachment will remain with them in their heart, always remain with them. I have groomed a lot in many ways. My delivery skills, confidence, and counseling skills has enhanced. So these are the feedback we received from the community midwives. So overall study conclusion was, this study was able to give us the resilience pathway, the 6 core competencies. We were able to get the contextual and culturally validated resource in intervention. Also, we proved through our RCT that a non-medical strength-based psychological intervention can enhance resilience and can reduce depressive symptoms. Now, let's discuss some of the things we have identified through in our study. One is, if we'll focus on this 6 core characteristics, There were some personal factors, there were some external factors, like out of 6, 2 factors, 2 characteristics were like that includes the strengthening the relationship support system that connects an individual to the external factor, also internalizing spirituality and humanity. So though we wanted to have an individual resilience characteristics, attributes, but like knowing Pakistani community, we have identified 2 external factors. If we talk about the 6 characteristics, they are so broad that can easily be like we can easily generalize it to the whole population, especially the women. But we can't say it because we only took the data from the pregnant women. Also, it depicts the role of Pakistani women who have been, in which it is the ingrained, or I would say that they are being trained like this. They have been developed or grown up like this by seeing their mother always giving up her own wish for her husband or for kids. So they have learned this way. So our study has identified, the phase 1 data has identified the true picture of Pakistani women. Now, if I talk about the phase 2, though our results shows that the study, the SMART has shown improvement in resilience and reducing depression, but we should not forget the dynamics of group session, because the whole session was within group. So we can't eliminate the factor of group with the SMART. Okay, so as this study proves the higher resilience, the study has shown the increase in resilience and decrease in depression. So it can be implemented at the antenatal level. We did not see any improvement in marital adjustment, and which is quite logical because we have not engaged the male partner. So that's quite logical. We did not get an anxiety. Though we have not seen the differences between the group, but we have seen differences within the group, maybe because of the time. This was a COVID time, and we have been calling them to both the groups about giving them the reminders, either to the intervention group, we were calling them and giving them the next day of their session, and to the control group, we were calling them, asking about how they're feeling, and then we were giving them the dates of their next assessment. So maybe a call during that pandemic time reduces some of the anxiety. Limitation, we only have 200 samples. And the first qualitative interview, 4 out of 5 hospitals were private. Though it were the AKU secondary hospital, which are based within the community, but again, the functional lead is the AKU, which is renowned for its practices. Measurement tools, though we have used all the validated tools, even the resilience scale, which I validated by myself, were used in the study, but we decided about the tools prior, but the characteristics, the attributes that we have identified, that includes the spirituality and relationship, were not being part of this tool. So we are not sure whether whatever results we have were actually depicting the data, because we know that for our population, having this faith on spirituality, having the faith in the divine Allah is very strong to them, and which has not been assessed here. Okay, the last our limitation is we have only invited those for their reflection who attended all 6 sessions, but we have not invited those who have missed the session. So if we would have invited those, we would know that what are the factors which stop them coming to the session, whether it's the family consent or what. So this was missed, and that's our limitation. So this study shared few potential areas for future research. From the reflection part, from the focus group after the study, the women verbalized that you should invite our husbands, you should invite our mother-in-law to attend this session. So the decisions can be, because they are the decision makers. So the positivity can be transferred to the family. This was the one of the. Also, they have, we as a team of researchers identified that we only assessed during the antenatal time. It was just pre and post. So we should assess after the delivery, or maybe after a year after the delivery. So we can see how much this intervention can retain, and will the whatever the responses we have now are the same, or there is a change. Because actual check during considering the Pakistani culture, actual check of family support comes after the delivery, because after initial 3 months, the mother is she's actually at her own home with her own parents, where she has a good support. But after 3 months, when she goes back to her in-laws, where this is a time to test the resilience. Also, we were thinking to have some soft and hard outcomes, and we should involve the partner as well. We should test the children's outcome as well. Also, we recommended that this can be replicable to different adversity, different age group, and different socioeconomic status. These were the PhD supervisory committee, and I was blessed to have a global team. And these were the thesis evaluation committee, and I'm again blessed to have a global members here. And with this PhD, with research, I was able to complete and get the degree. And it's exactly a year before, this October end 2023, I defended the thesis. Okay, after that, and at the time of starting this research idea, from that time till date, I have been promoting this concept in the area of for Pakistani population. So these are just global outreach and the dissemination activities. And this was the national spread, where I tried to do research, where I tried to provide services to promote community work, resilience building work. These are the funders who have been funding my research throughout my research journey, starting from the masters. Okay. Now I'm done with the PhD research. Before I move into the postdoctoral research idea, would you, if you have any questions, so I can take a question now, or you want to get it done? Okay. So based on the recommendation we have in as part of PhD, so considering all those recommendations in mind, what we are planning to convert SMART, which was individual resilience building intervention, we propose an intervention where adapting SMART to SMART Plus, and we were thinking to name it as a Sahara. Sahara is an Urdu word which means support. So we are considering family as a source of support for each individual resilience and growth. So this is what I'm thinking to do as part of my postdoctoral fellowship. So this would be the methodology. We are still thinking, and I would be needing your guidance, your suggestions to improve it, to make it more rigorous. So initially, as part of PhD, it was only women who were giving the SMART intervention. Now we are changing SMART intervention, considering all the individual factors and also factors related to the family level and also at the societal and community level. So that if you can see the climate affected places as well. So we were thinking to go now to those areas which are more prone to climate impact. And we would be taking we were thinking to involve pregnant women living in those areas. We will be inviting their families and giving the whole family this SMART intervention. And definitely this prepared intervention needs some modification, needs some amendment, some changes based on the group, now the different groups has been involved now. But this is our idea right now. I'm here with some suggestions, some discussion points where I need your suggestion. We as a team, because I have mentored Dr. Vikram, Dr. John, both have been contributing in this idea. So we are thinking whether we should go SMART, RCT with two intervention, where one group should have the same SMART, previously tested SMART intervention, and one with SMART Plus. That's the option one. Or we should test SMART Plus directly, because we know that SMART is already shown the effectiveness. So directly one group with the SMART Plus, and then the other group as a control group without SMART Plus. So any suggestion we can think, we can discuss. And also, we were also thinking for a postdoctoral research that what should be the unit of measurement. That's very clear about the unit of intervention. We'll be doing the intervention to the whole family group. But who would be our unit of measurement? Are we planning to assess only pregnant women, or pregnant women with children, with a newborn, or the pregnant women with whole family? If we are going with whole family, what about the number of family members? Because there would be family who would be based on 2 members, but there would be families who would base would be based on more than 2 members. So this was another point of discussion that we can discuss. Also, we were discussing about what would be our primary and secondary outcome. Are we thinking for resilience, mental well-being, or no, because we are taking the climate changes also in consideration for this research. So climate anxiety, like are we thinking of outcomes related to the climate impact, or the family related measures? Because now we are inviting whole families for the intervention. So family cohesion, family support, family engagement, family involvement. Also, we are inviting the couple, partner. So are we thinking to assess we were also debating whether to look for intimate partner violence, marital satisfaction, because now we are inviting the male partner as well. So this is what okay. So this is about what I wanted to share with you and wanted to have your suggestions.
Thank you so much, Shireen. This is just a fabulous piece of work, just like Mary's doctoral program thesis. It's just wonderful to see the research you've done, which is so original. I had a couple of questions, and then we can maybe about the PhD work. Okay. You can have some discussion, and then talk about your postdoctoral plan. I just want to ask you firstly, resilience is a very complex construct, and there's a lot of people who've been doing very similar work in other cultural contexts, particularly like in North America. In fact, I think in Dalhousie University, there's a very prominent
resilience center.
There's a big resilience research center, right? So I wanted to just for you to comment that you've developed a kind of framework of resilience, very grounded in the right kind of way, almost ethnographic. So just how does that compare with resilience? And that's just one thing. And the second is, when you are, so I didn't realize till quite late in your presentation that the intervention is a group intervention.
Yes.
So groups of mothers collect. I hadn't realized that. I just also want you to comment, I don't know when Pakistan, if this is already part of the system, but in, I've read like Atif Rahman's work, where he describes groups of women, maternal, groups of women who are pregnant or having babies coming together as part of a long-standing tradition in Pakistan. So even his CBT intervention, which I'm sure you're familiar, the Thinking Healthy program, there was a group format as well. So I just wanted to hear, are these groups specially constructed for your intervention, or are you using established groups and piggybacking onto them?
So I'll answer your first question. So first question, while developing this this framework, we did consider several frameworks which were existing, but we thought like it has a very Western in nature. So for Pakistani context, we should come up with our own, but we did consider all the frameworks while developing that interview guide. And based on that interview guide, like what are the factors we really want to explore while interviewing. And so we did consider that framework while developing the interview. And once we had the data, or based on these 6 themes, then we compare our results. So there were similar constructs that were there in their framework too, but the combination was very different. So the combination that we have was specific. We thought like it's specific to our population, because spirituality was not in every framework, so which was very evident in our framework, and also the relationship, the expectations from the family members. That these were the two which was not evident in all the frameworks. So there were some factors were similar, but the combination and these 2 factors were different. So this was your question 1. The second question was regarding
the groups.
Okay. So in Kohigod, though I do understand from where you are asking this question. So in some part of Pakistan, in some antenatal clinics, like if I talk about the Aga Khan University. So Aga Khan University has this set practice that every woman who has registered for antenatal practices, she would be asked to join our antenatal group, where they have a 4 session throughout the 9 months. But in Kohigod, there is no such practice, because in Kohigod, it was delivered free of cost. It was based on community midwives. So there was no such practice. So we asked them to come for our session only. But when we completed this study, we did the dissemination at the hospital level. We did promote our result. We did try to convince them, and I don't know whether they have continued, but they were in debate of initiating such idea.
Mary.
So I just had a question, Shireen, about the intervention, because the period of pregnancy, the perinatal period, is a very peculiar one in and by itself, just by the state of mind of the woman, etc. So was this intervention designed to promote resilience in this period? Because even just the state of mind of women in this period and any other periods are very different. So I'm glad to see that you're measuring childhood outcomes in a SMART class, because that can be a good measure of the impact of this intervention in the perinatal period. So that is my first question. And then I was just wondering, again related to just the peculiarity of the pregnancy period and the context you presented in Pakistan, the isolation, the loneliness of women, is it really that the resilience intervention is what worked to reduce the symptoms of depression and anxiety, or was it the social support that you're providing by being there, engaging with them, and just showing concern compared to everyone else? And related to that, can you just comment on reporting bias? So would they have just been glad that you are there with them throughout the journey, or was it actually the intervention?
So regarding your first question, so yes, while planning an intervention for pregnant women, it's always a debate because they are already going through several hormonal changes, which actually leads to several mental health issues. But when we did in-depth interviews with them, the problems they identified was not only related to the pregnancy. It was related to the women's life. It was not solely related to the pregnancy. Rather, several of the women shared that during pregnancy time, they were being more pampered. Like this is the time, and that's why they are okay to have multiple pregnancies. Because this is the time they have been more pampered, they are more careful by mother-in-law, by the partner. So even during the sessions, and even after that, they asked, because all the strategies, though are the module that we develop, the intervention that we develop, if you see each page, each examples, each activity, we purposefully wrote during this pregnancy time, if you have been asked it. But the discussion we had during the session were general comments, were generally related issues, not specific to pregnancy. So this was your first question, answer of first question. The second question, as I mentioned, yes, the influence of group dynamics cannot be taken out from the SMART, and we know that group therapies are very well effective in a culture like Pakistan, and where these women are hardly get time to go and talk about their issues with those who are going through the similar stages, right? So yes, we can't taken out the impact of group session from the SMART, and that's I have mentioned in my limitation that we will be saying this, that SMART plus group, SMART in a group, shown the effectiveness in resilience and depression. And what was the last question?
Reporting bias. Do you think there was any reporting bias?
Yes, I think there may be a reporting bias, and that's the that's the reason we said we should have the repeated measures. So and we can see how much the content they have been practicing, and the results are similar after maybe 6 months after delivery, or maybe after a year. But I'm sure there would be some reporting biases. They were trying to hide the true picture.
And I think if you have a long time,
but we made sure the confidentiality was there. We make sure they have been interviewed in a private place where nobody is there. We make sure your father or your mother-in-law is outside, because they in the same setting, the husband were not allowed, because it's free. It was all females leading and managing by females, because midwives were also. So only they were coming either with their mother or mother-in-law. So we make sure that your mother is outside, you can share. And those who were able to write, there were very few. Only 4% were a participant who were educated. So we asked them whether they want to fill it by themselves. So we asked them to continue filling by this. And those who needed our help, we were asked them we can say, and you can fill it on your own. So these are some measures we use.
Yeah, I think if you get a long funding period, a very good objective measure would just be to see the childhood outcomes, because we know the impact of maternal mental health on the developmental outcomes. So that would be a good measure.
Yeah.
How would you disentangle the effect of, because this question you're asking about is it the group dynamic or is it the psychological resilience intervention applies to all group interventions. Group IPT is a good example, the original trial from Uganda. How would you disentangle that effect?
That's a difficult question.
Well, I guess what Atif did in his original Thinking Healthy program trial was that he had sham groups, which is basically not the same. It's essentially you have women still meeting in a group. And that is why I asked you about this, because in the part of Pakistan that he did the trial, the women's groups were already meeting. So therefore, the control arm already had groups. But what they did in addition in the Thinking Healthy arm is that they incorporated the cognitive behavioral techniques with a lady health visitor being a kind of facilitator. So that actually takes care of Mary's concern. But if you don't have those groups, you can't just make up groups where people talk about the weather. It's like not like So you can only do this in places where groups are already occurring, and then you piggyback. That's why I was asking you that question. But it also lends, going to your postdoc program, if these are safe spaces for women to meet as groups, maybe I know Gloria had a question, but one question I want to just flag up for you to think about, you don't have to answer it, is how will you incorporate family members, especially husbands, in what are women's safe spaces in patriarchal context, how will that work? But if we have time, we can return to that question. Gloria.
I'm just going to just one last question, perhaps an ethical one related to your suggestion, Vikram. I mean, the issue of equipoise. So would it be ethical for us to have sham groups where we are not implementing this?
It's very difficult. I would say from an ethical perspective, it's because there is a cost. For women, there's a time cost. It's a big time cost. And if you know that something is just a sham control group as an IRB, I mean, I think some people question. And this is the tension between trials that are intended to answer questions about mechanisms from trials that are pragmatic. And the work that we do in this lab will probably not be in the former category. I personally have never done primarily a mechanistic trial. But people working in laboratory situations or highly controlled clinical efficacy trials, yes, they will do sham trials. To unpack what is actually the active piece. But in global mental health, I think Atif is one of the few who did it, but he did it because he could do it. He didn't create an artificial control group. Gloria.
Yeah, this is really brilliant work, and thanks so much for all these insights. And I love just seeing how it was your whole journey throughout your education. So that was fantastic. I was just going, so there's a question and then just a couple of thoughts. So one question was whether or not you gathered any feedback in that post-qualitative on what they felt was the most impactful in the session for each of the sessions, if there was any session that really pulled on to them, or if you do feel like it was the whole package of the interventions.
So yes, we did ask about this, and we also noticed while developing that each session can stand alone, but we give them as a package.
So that's great, because my other two thoughts was consideration of exactly how you'll involve the family, because it sounds like if you were to create this as a family-based intervention, then you really would have to kind of recreate the intervention itself, and now you cannot compare. If you wanted to compare, an opportunity could be to find out what is that more of the unique safe space, as it were, for the women bonding sessions versus one that could bring along a husband or a mother-in-law, or having one separate individual session that's just for the family, that concentrates on one of the topics, which might be the social connection area or some specific aspect that, or the spiritual, based on your data, I don't know. But I would think exactly, I think it would be complicated to kind of try to consider that now we want to target the whole family, because you really won't be able to extrapolate. And then the other thing, just in terms of the mechanisms, is, it won't answer the group effect totally, but you could consider measuring the skills and the competencies of the group facilitators, as well as the quality to which they deliver, and then kind of see whether or not that has some sort of a mechanism impact to the mechanism of change for the outcome. So as a moderator or a mediator, it could be one way of looking at it, since there was such a great impact on the midwives, it seemed like, as well. So just how well they're actually doing the job that they're supposed to be doing.
Yashika?
So I had a suggestion, kind of a question. So for your postdoctoral thing, like building upon Mary's question that what time period of the pregnancy you are focusing on, and if you have six interventions over 6 weeks, you could focus it on the 9th month and probably look at the postpartum depression, because that is the time when the actual depression hits and she has delivered the baby. So probably the effect of the family and the support of the family will go away, more in the sense the pampering will go away. So you could divide like 3 before and 3 after delivery sessions, and that way you can see if delivery and if the what effect your intervention has on postpartum depression also. Because I think still like I'm not sure if there is literature, but the postpartum depression is more common than depression in antenatal period. You could think about this as a probable thing.
Javier? Oh, so Diane?
I have a quick question. Were you able, sorry if I missed that, but were you able to control for socioeconomic factors and also for kids' outcomes? Because, for example, Flavia's study, she's studying how the mental health of the mother impact on the kids, but the other way around also not the mental health of the kids, but the outcomes of the kids also impact on the mental health of the mother. For example, in Brazil, there was a critical period where Zika virus, I don't know if you guys saw, many kids were born with, they had very small and development, speak everything. And those mothers got a big proportion of them became depressed and everything. So I wonder if you were able to collect in this.
Yes, so we did, like, as I mentioned, we did several different analysis and we did modeling. And we measure each variable that we collected, whether it's related to the individual, any comorbidity, any family-related matters, any demographic. So I did not present the data here, but yes, this did not come as a significant factor. When we
The
did
kids, so you collect data about the
No,
kids?
we did not collect data from the kids, but we asked from the mother for about those, like if a mother if it's a secondary pregnancy. So we did ask about the first pregnancy, how did it go, how are the kids, and how old they are, what is the gender. So we did ask about the earlier pregnancy from the mother, but we did not take the data from the children directly.
I think it would be interesting for the next
This
round.
would be it. So that's what we were thinking about to plan our like postdoctoral study for a longer period of time, from antenatal to postnatal or till the child of 1 year.
Yeah. And maybe ask if the kid has any disability and if the form is not too big, which disability is. I don't know, it might help. Also, can I ask you about follow-up? Do you have problems? Because one of the main problems with this type of research is loss of follow-up, and also if this loss is biased or not. Like people who are feeling better, they tend to follow more. People who are not feeling so great, they tend to leave. So you have it.
Yes, we have captured all the data, which like how many of these 100 women attended 6 out of 6 sessions. There were some who attended 4. There were some who were drop out soon after the pre-assessment. So we have all the data. We try to analyze like whether we have seen the difference at session 1, regardless of whatever the session they have attended, whether it was a first session and whether it was a third session. Maybe there was some participant who started joining from the third session. So we did several types of analysis, but I've not presented, but I can share the papers and I can, because the third, okay, so third paper has all the details.
Amazing. Yeah. Congratulations.
Thank you.
Very incredible work. I really enjoyed it.
Just to follow up Diane's point, I think what she also is referring to is the health and well-being of the index newborn. Not the previous. Yeah, although that is also important, of course. And that, for example, a loss of the child, which is the most extreme form of psychological impact, would clearly mean that mother has a very particular need. And is that need going to be met by a group in which the other mothers have all had a live birth? Do you see what I mean?
Yes.
So there is a subgroup of highly vulnerable women whose pregnancy outcomes.
So that's a very good point. Actually, we have, if you have noticed, there were some dropouts due to stillbirth and abortion, right? So they actually excluded from the study. They decided not to continue, and because our intervention we were actually based on the pregnancy related. So, but that was a good point. We can consider this in our upcoming research plan. Like we should at least assess some measures or do the qualitative interview with them to know.
Well, certainly, and from a very straightforward ethics perspective, to provide additional support to those mothers at the very least.
Yeah, please.
That kind of leads into my question. Could you speak a little bit more about what the selection criteria is for these women starting
For
out?
phase 1?
Yeah,
For
and then
both, okay.
also like what the referral pathways were for women who maybe their clinical outcomes didn't improve or they needed additional care.
So if I talk about the phase 1 first, so for phase 1, we have included all those women who are from the 12th week of pregnancy. So from 12 weeks, if they are pregnant, if they have confirmation of pregnancy, we included them for qualitative inquiry. And because I was taking the interview, every time my research assistant was with me, she was a psychologist. So for any emergency situation, she would have been there to provide the counseling for phase 1. For phase 2, we decided from 12 weeks up to 30 weeks. And why we made this bracket? Because we wanted to have some time for the intervention. So if we include the 36, we may not have the 6 weeks time. So for phase 2, we have an inclusion criteria of 12 weeks to 30 weeks. And the one who was the research assistant who was a psychologist, she was unblinded. She was the one who actually do this allocation, and she was present because she was part of me, with me while training. So she was there. She was there. She was sitting outside the room when the facilitators were doing the intervention. And during the session, if there was incidents happen, like during the session, there were 2 participants who wanted to have some time, some counseling time. They wanted to burn out some feelings. And she was there all the time. Mm-hmm. So we did counseling up to 2 levels. So we have been calling them. We have asked them to come again if they did not come afterwards because they were scheduled to come after a week. Mm-hmm. So they did not turn up, but we provided in our consent that we will be giving the counseling up to 2 levels, and then if need be, we would be referring them. So all the participants at the time of consent, they have been given the referral list of the local who have been providing the services at a very low cost.
But those that were screened in didn't necessarily come in because they have depression or anxiety to start. Okay.
I guess one of the other issues you might want to think in your next project design, just following on from my point about the involvement of men, I think it's a very important, it's obviously a very important group if you're trying to build solidarity. But then what are the risks attached to that? How will that affect the dynamics of what you have doing? It can be a profound influence to have men in the groups that have always been only women, and especially the vulnerability for those women who are living with violent partners. These are complex issues, and there's a lot of work in that area on how to create safe spaces. And so obviously you want to maybe refer quite a lot to that when you start talking about groups which include other family members in very patriarchal systems, which your talk began with speaking about the lack of agency of women in this context. So then doubly so, the reviewer is going to ask, how have you managed the safety issues here?
As for Vikram's question, I was thinking if you thought about like a mixed modality, because I feel like in the literature, when men or other caregivers are included besides mothers, it's normally more of a home visiting format. I think there's group interventions too, but do you think that could be feasible? What would be the downsides perhaps of having both a home visiting component, but also a group component of mothers?
If we are thinking to provide and we want to go for a family approach, then we may need to go through the home visit approach. So because it depends, like inviting all the family members, we don't know about each member's schedule, so it would be more convenient to go to them. So that we can think, Yes.
Oh, I think you mentioned again, I may have missed this, but you talked about you noticed that different components of the intervention were working just as well by themselves. I think you mentioned something.
Sorry, can you repeat?
If I got this correctly, you said that each of the 6 components of the intervention, you noticed that each was actually working very well independently.
So when we did the model building, we considered their attendance for each session as one of the variables, right? And we noticed like the one who have attended, like those who shown, because here we did the combined analysis, we did not see the individual results, But we noticed that the one who have only attended one session, and that was only the spirituality one, for instance, and she has shared, that was a 6th session, the last session, and soon within 15 days, she shared she shared about the depression scores were like less, right, compared to the previous score. So we noticed that with one session, we can see the change. So that's where we thought like each session can be standalone. We can test each session separately, because but here we have only the whole in one go we saw the combined effect.
So maybe that's another thing you can
Yeah.
think about in future work. You want like the most parsimonious intervention with as few modules and as effective as possible because of time, cost constraints. So that's another thing you can think about testing.
Or like taking Gloria's point, if we can decide to have like out of 6, there were 2 which includes the external factors. So we can do for family intervention, we can only focus on those 2 factors. Remaining we can go with individual one. So like Lucy will talk about this.
I guess the most scalable kind of interventions will be those that are piggybacking on existing delivery systems. And I know that, again, I'll go back to the fact that during this period of pregnancy and early childbirth across many countries, the healthcare system is already delivering, not for mental health reasons, a variety of group level interventions to promote antenatal care, to promote institutional delivery, to promote early childhood immunization. And the extent to which you are incorporating your techniques and components within those, the more likely it is to be scalable. Because you have to always ask yourself the question, if I create a completely parallel new group on resilience, what is the probability that they will create, anyone's going to create a separate group system? You know, the probability is quite small. So I think to Mary's point, you know, to be able to identify what you think is the critical piece that is going to build resilience, and how, because you know, it has to be relatively portable and it can be incorporated in existing delivery systems. The other thing we haven't talked about, and we don't have time now, but I wanted to just flag up, you know, your interest in climate affected areas is very important for the lab. It's a subject that has become extremely relevant. You know, the work that Ryan McBain did in Malawi is a good example. It's a highly climate sensitive country. And did that trial happen during that crazy cyclone? Yeah, it was. Yeah, you know, so I think what you need to think about carefully is how will you weave that into your design, because right now there is nothing about climate in what you're in your design. And we talked earlier about this, whether, for example, if you're following two arms of 2 cohorts in a trial, there will almost certainly over a period of 1 calendar year be climate events. And so to be able to examine during a climate event, like an extreme heat event or an extreme rain event, whether in fact there are differences in coping in your 2 arms as almost as on the pathway to your ultimate outcome. Because otherwise the climate factor becomes just superfluous. It's just there. It's there everywhere. So you can't really connect what you're doing with climate change. So think about that very specifically. How will you weave that into your research idea? Okay, well, thank you very much, Shireen.